Okay then, so side effects are kind of strange sometimes. Calcium channel blockers, you all. These are great drugs. We use them a lot for lots of things. So let's talk about the three classes of calcium channel blockers. There's two categories, different drugs in the categories. One category is called the non-dihydropyridines. Just a big mouthful that says there are two drugs in this category. One is called verapamil. You familiar with this drug? Sure. What it does, and the reason I have a heart here, is because it blocks the calcium channels in the heart, the coronary vessels and the AV node. When you block the calcium channels in the AV node, you slow the heart rate down. When you block them in the coronary vessels, you vasodilate. So you improve blood flow to the heart, good drug for angina. You also slow down the impulses between the atrium and the ventricle, good drug for supraventricular tachycardia. It'd be nice if I could stop here. The problem is it stops all calcium channels in your bowels. It is one of the most constipating drugs we have on the market. So is this a good drug for the elderly? No. They're already constipated. Why would we add to their misery? Why would we add to the prune bill? So, this drug is so constipating it will stop an elephant from having a bowel movement. I had to show you this picture, y'all. In Thailand, you know how smart elephants are? Have you ever read anything about elephants? They're brilliant. Brilliant. Unbelievable. You just hate to see them in a zoo because they're just standing there. They're just so darn brilliant. Anyway, in Thailand, they have these huge zoos for them. I mean, like acres and acres where they can run and do all sorts of things. But the Thailand zookeepers were so tired of picking up the poop. 100 pounds of poop per elephant per day. Yeah. So they said, you know what? They're smart. Let's teach them to poop in a toilet. So they built a toilet for the elephants. They taught them how to back it up, poop in the toilet, and pull the string with their trunk. I'm going to Thailand just to see this. I don't care about Thailand. I want to see these elephants pooping in a toilet. Anyway, so that's what they do. Now they don't have to pick up after them. So they all just back it up, pull the flusher, and off they go. Isn't that amazing? They're so smart. They're just so smart. Anyway. Alrighty, so the second category of drugs in the non-dihydropyridine category is called diltiazem. This drug is a cardiologist's dream. They love this drug. They love. Not only does it work in the heart to block calcium channels, so it's good for supraventricular tachycardia, angina, but it also works in the peripheral vessels to vasodilate. So it's a great drug for hypertension. How many of your patients have angina, supraventricular tachycardia, and hypertension? Lots of them. It's a perfect drug. It's got a lot of names. Dilicor, Cardizem, Tiazac, there's a zillion names for it. But it's a great drug. Very few side effects, less constipation than verapamil. Atrial fibrillation, hypertension, angina, vasospasm, it's also renoprotective. So if your patients cannot take a Pril or a ARB, this is a drug to use to protect kidneys. All right, then our last category is the second category. We've got the first category, the non-dihydropyridines, and then these are the dihydropyridines. And the easy way to remember these, y'all, they have the last name dipine. So dipines are your peripheral calcium channel blockers. You know them: amlodipine, felodipine, nifedipine, nicardipine, isradipine, isoldipine, clevidipine. These are all of your dipine drugs. Number one seller in the world is Norvasc, amlodipine. The older ones, the nifedipines and the nicardipines, those are the first ones out. Us old nurses remember those. They used to take them 4 times a day. That was bad because they would have what was called reflex tachycardia. So when you drop the blood pressure, the heart rate would immediately go up, and that could actually trigger an MI. So they said, ooh, we don't want to do that. So now they made all those older drugs basically are taken once a day. Most of these are taken once a day. So Procardia XL means what? Extra large. Lots of names for these. So anyway, there's not much else to tell you except for some of the uses of the dipines, of course, would be for high blood pressure. The dipines don't work centrally in the heart. They only work peripherally. So they're great drugs for blood pressure. They also work for vasospasm. You can add 2 dipines in a patient. You can use diltiazem and amlodipine. You can use 2 calcium channel blockers in the same patient. That's okay. What's Prinzmetal's angina? You cardiac nurses. This is vasospastic angina. Vasospasm. Who gets it, men or women? More women than men. And when we usually see it is right around between the ages of 47 and 52. What's happening? Your ovaries are in limbo. They're on a roller coaster ride. One day they're making 700 micrograms of estrogen, the next day they're making 70. So it's like whoop, 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 and that's causing the penetrating arteries that go into the heart muscle to spasm. Most women between 47 and 52, their big conduit arteries are clean as a whistle. You do a cardiac cath on them, and their arteries are wide open. It's the penetrating arteries that are doing the squeezing. So how do we treat you? You're not having a heart attack. You're having vasospastic angina. You don't really need a statin because you don't have any fat in your arteries. There's no plaque formation. So we can put you on a calcium channel blocker. We can also put you on, interestingly, nitroglycerin, which would keep open the arteries. And generally, we'll throw you on estrogen. Put you either on a birth control pill that has some estrogen to straighten out the fluctuations, or go ahead and throw you on Premarin, or one of the estrogens. All right, Raynaud's phenomenon. When you see somebody with Raynaud's phenomenon, what do you think? Or do you think anything? Or have you never seen anybody with it? Raynaud's phenomenon can be either primary or secondary. Primary means there's no underlying cause. It is the only thing going on in this person. Vasospasm of the end arterioles. However, don't just write it off as that. If this is a woman between 20 and 40, she most likely has another autoimmune disease. She has something else going on at the same time. She may have rheumatoid arthritis. She may have lupus. She may have MS. She may have, why do I say she? What's the percentage of people with autoimmune diseases? Of 100 people in this room with autoimmune, how many of them are women? About 80. 75 to 80. So Raynaud's phenomenon can be a sign of an underlying autoimmune disease. And sometimes it's not. One of the things I suggest, if it's not, let's say she doesn't have any other thing, and she only really gets it in the wintertime, when it's really cold. Now, this is not FDA approved, you all, so I have to tell you that. I can't just tell you to do something that's not FDA approved. This is not FDA approved, but one of the things that we can use, interestingly, is a little nitroglycerin paste. So put a little nitro paste. She's going to go outside. She knows she has to go outside. She has to be outside for a while. Just a little bit of nitro paste on her fingertips. What does that do beautifully? Oh, my God. It's the best vasodilator in the world. She can even put it on her toes. You're not slathering on her whole body. You're not up and down. It's just a little dab will do you, keeps your vessels open, and you don't get the extreme excruciating pain that you get with this vasoconstriction. We also, if you have it really badly, will put you on a calcium channel blocker to keep you open all the time. Okie dokie, cocaine-induced vasospasms. What's your chance of having a heart attack if you go out at lunchtime and do a line of cocaine in the car? Just to get you through the rest of the afternoon. Oh my God, I got to sit here until 3:30. You crazy? So, your chance of having a heart attack in the first hour after you do that line of cocaine is 24 times greater than the person sitting next to you. So, it's just a potent vasospasm, or a stroke. So you'll come back in, well, I just did the cocaine just once. But my point being is, it's such a potent vasospastic agent that that's why people coming into emergency rooms doing cocaine, or methamphetamine, another very potent vasospastic agent. Heart attacks, strokes. But we want you to tell us the whole truth and nothing but the truth, because generally the only way we can treat these is to use these calcium channel blockers. So, are you doing cocaine? Why do they lie? They're such notorious liars, cocaine users especially. Oh, no, 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 no. Their pupils are dilated, their jaw's sticking out. No, 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 no. Their nose is dripping. No, nope, 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 don't touch stuff. Don't touch stuff. Temperature's 104. They're going to lie to their grave, basically. Unlike your marijuana users. You got to love them. You smoke marijuana? Oh, yeah, I had a joint on the way in. How long is it going to be before you see me? I'll go out and have another one on the outside. So it's a whole different world out there. Anyway, ureteral spasms in patients with small kidney stones. Is there any such thing as a small kidney stone? You know, it made me laugh when I said, oh my God, are you crazy? They're all killing you. Morphine or Dilaudid is the only way you treat kidney stones. Forget the calcium channel blocker. And then, interestingly, a male contraceptive. This is very fascinating. Not that you'd trust them to take it, their pill. Honey, have you had your pill? Yeah. Come on. Sure. Anyway, so the interesting part about this was, well, first of all, the picture. You're looking at the egg on the left and the sperm on the right. Look at the egg, you all. She is 1,000 times bigger than that sperm. I learned in nursing school she was passive, and the sperm was the aggressor. That is the furthest thing from the truth. The egg is the aggressor. She's the one that says, come on up. And look at the sperm. Can I come in? No. So, in order for the sperm to enter the egg, there is a drill on the head of the sperm. That drill has to have calcium to start. If they're on a calcium channel blocker, the sperm will not drill into the egg. It'll bump it. It'll keep going. Oh, so it won't. It's got a terrible headache afterwards. It will not go into the egg if you can't get the drill started. And they finally figured this out with these kids that were young people were coming to the emergency room, fertility clinics, couldn't get pregnant. They looked at everything. Thyroid hormone, all the things you look at for fertility. There's a million things. Nothing was wrong with these couples. The only thing they had in common was all the guys were on calcium channel blockers for blood pressure. So they finally said, oh my God, I wonder if it's something to do with calcium. Somebody was brilliant enough to think about that. So they went back, pulled a few sperm out, looked at them under the microscope. Sure enough, there's a Black & Decker right there on the forehead. And that thing would not start up until they had calcium going through it. As soon as they took every single guy off of their calcium channel blockers, every woman was pregnant within 2 months. Amazing. So the reason we're never going to use these as male contraceptives, trust me. But if you have young couples trying to get pregnant, one of your first questions, besides working them up for $1 million fertility workup, check to see if the husband is on what? Calcium channel blocker. Whether it's verapamil, diltiazem, or any of the dipines. If they are, stop that first, put them on another blood pressure drug, and see if that would be a very simple and cheap way to treat the fertility problem. Alrighty, so your side effects, of course, are verapamil, significant constipation, lots of drug interactions with verapamil, you all. Dipine, significant peripheral vasodilation with headaches, so it's hypotension, peripheral edema. Diltiazem, less significant constipation than verapamil, and all the calcium channel blockers actually can cause acid reflux. This is a lesser-known side effect of these drugs. There's a lot of drugs that cause GERD. Lots of them, which we'll talk about later on when we get to those drugs. But throw this in as a possibility as to what's causing the GERD or heartburn in your patients. Could be the calcium channel blockers. Okay then, how are we doing on time? All righty, good. So let's talk about your statin sisters. Who are they? Lova, Simva, Atorva, Fluva, Prava, Rasuva, and Pitava. These are all your statin sisters. Which one do we rarely use anymore? Lova. Do you see Mevacor used? Nah. Very rarely do we see it. By the way, this is the actual drug that's in an over-the-counter product called red yeast rice. So when people say, I'm going to take red yeast rice for my high cholesterol because I don't want the side effects of the statin drugs. Well, guess what? Red yeast rice can also cause muscle aches and pains. Can it reduce your cholesterol? Yeah. But you're not going to get any less side effects from it. Simva, Atorva, and Rasuva are your strongest statins. They're the big guns. Simva, Zocor, Atorva, Lipitor, and Rasuva, Crestor are your top bananas in terms of their strength. Of those three, Crestor is the homecoming queen. I honestly have to tell you, I don't know much about the newest statin out called Pitava, Livalo. I don't know much about the comparing and contrasting of that drug with the other ones. But I do know that Crestor number 1, Lipitor number 2, and Simvastatin Zocor number 3. They're all right up there together. But if you want to do the 1, 2, 3, it's Crestor, Lipitor, and then Zocor. So what do? They work in your liver to inhibit an enzyme that's responsible for the production of the bad cholesterol called LDL cholesterol. Your liver does most of its work at night. It's just part of how your body works. It's on a body rhythm that says, I'm going to make most of the cholesterol for you between 11 and 7 a.m. And then right around 7 a.m. it goes, bleh, here it is. So when is your cholesterol highest in a 24-hour period? In the morning. It's lowest about 5 in the afternoon. So if you're drawing cholesterols on patients, it's best to do it at the same time of day. So if you know that your patient come in right before work and they had it done at 8 o'clock, then the next time you draw it should be at what time? 8 o'clock. It can significantly change from 8 until 5 in the afternoon. It can be as much as 60 points less at 5 o'clock in the afternoon. So if you don't want high cholesterol, when should you have it drawn? 5 o'clock in the afternoon. Okay, so here is why I'm telling you this little biological rhythm. If you're going to give the statin drugs to patients, when should they take them? At night. It will do a better job. It'll still work if you give it during the day. It does a better job at night. Now, the exceptions to the rule, there are 2 drugs that it doesn't matter when you give them because their half-life is so much longer. So Lipitor, atorvastatin, and rosuvastatin, Crestor, have long half-lives. You can take them any time of day. Simvastatin, though, should be given when? Night, or before bedtime. Well, what if I work nights? When should I take it? Okay. When do you sleep? Oh, okay. All right. So your bad guy is LDL. It's the most atherogenic of the cholesterol bunch. Puts fat right smack dab back into the arterial walls and starts packing those walls. The statins reduce the LDL cholesterol. They reduce the size. Well, reduce the LDL, reduce the risk of coronary artery disease. There is no doubt about it. Statins save lives. No doubt. Statins extend the quality and the quantity of your life. Oh, but Barb, I read in Prevention Magazine that they're terrible. They're evil drugs. No, they are not. They are very safe. They are very effective. They're so safe that in Europe they're over the counter. You can buy them over the counter. Yes, there's side effects, but what did I tell you? All drugs have side effects. So for all the people running around screaming about how bad statins are, they really are not, you all. You're listening to people who don't know what they're talking about. I actually had to talk right after a naturopath one time. I don't think that naturopath knew what hit her. I mean, I just reamed. I didn't ream her, but I said, what you have said is not true. You are not telling the whole story. Of course, I would love for everybody's cholesterol to be lowered with diet and exercise. Wouldn't you? Sure. But nobody does it. Nobody will. Well, I can take a drug. Why should I do that? And that's exactly what people think. So honestly, there are things you can do. Yes, you can eat yogurt and almonds and things that help to lower your cholesterol. But there are some people out there that eat all that all day and exercise 23 hours a day, and their cholesterol still will not go down. Okay, so the other thing I want to mention, it reduces your risk of kidney disease, heart disease, and cerebral vascular disease. Now, last but not least, before we have to finish this tape, I want to talk to you, though, about something very important, and I hope the Springfield Clinic is doing this, and maybe if you're not, you should ask to have it done. It's called particle size. What is the size of your LDL? It's not just enough to know what the LDL number is anymore, you all, because we know there's good LDL and bad LDL, or there's bad and worse, I should say. So the particle size makes a difference. The test today for particle size can cost anywhere between $39 and $100. When we were first doing it, it was over $2,000. No wonder we didn't do it, but a $39 test is well worth it. So if your LDLs are pattern B, which is called small and dense, you have a much higher risk of heart disease than if your LDLs are pattern A, which is large and loose. So what the heck does that mean? If they're small, dense particles, they pack into the arteries much easier. They slip right into the arterial walls and make big old plaques. If they're large and loose or fluffy, they can't get into the walls as easily, so you have less atherosclerosis. So what do you want your particles to be? You want pattern A, large and loose. Easy to remember, ladies. Would you rather be large and loose or small and dense? We all know what answer that is. So, the interesting part of this, and then I have to probably shut up because the tape's going to go. People with high triglycerides have small, dense particles. So, the interesting part of that is, what is one of the major components of diabetes type 2? High triglycerides. These patients all have what kind of particles then? Small, dense. Do diabetics have heart disease? Ad nauseum. We've got to do what? Protect their hearts? Should all diabetics be on a statin drug? The answer is yes. If you say, I don't know, change your answer to yes. Because statin drugs change the size of the particles to large and loose. That's one of their other functions. They also lower triglycerides. So statin drugs are very good for you. Yes, they have side effects we'll talk about after lunch, but suffice it to say, they are good drugs. This next slide, of course, I've mentioned to you already about who does the best work, but this is just kind of it gives you an idea of how much of a certain statin will give you a specific lowering of the amount of cholesterol, LDL cholesterol. And actually, the interesting thing about statins is you don't start with the lowest dose. So most of the time when you talk about drugs, you start low and go up. But with statins, we try to start at a higher dose to get your cholesterol down faster. And then we can adjust according to side effects or to how fast it goes down. So, for example, if you give 5 milligrams of Crestor, you should actually see a 45% reduction in your LDL cholesterol. It's a really strong drug, you all. So again, these are things you should expect. Doesn't happen in everybody. You might see less in some patients, more in other patients. These are just the expectations of how low you should get those cholesterols down with this particular dose. We do now say don't ever give any more than 40 milligrams of simvastatin. That certainly has come out. The FDA has recognized that the 60 to 80 milligram doses of simvastatin are associated with a much higher risk of rhabdomyolysis. So they do not want to go above that 40 milligrams if at all possible. Now, you might have some patients right now that are getting 80 milligrams of simvastatin and they've been getting it for the last 30 years. There's no reason to change them. No reason to go, oh my God, come off your statin, you're so core. You might want to lower it and see if they do okay with it. That's fine, but don't run around with your hair on fire calling them up saying, oh my gosh, oh my gosh. Okay, so guidelines, of course, just very quickly, we look at your LDL guidelines. Do you have heart disease already? Do you have a risk equivalent for heart disease? Now, I don't know how much you all are up in the world of cardiovascular medicine, or if you work in it, or if you work with a lot of diabetics. We used to say that diabetes was a cardiovascular equivalent. There are some people that are saying that's not true anymore, but so I don't care one way or the other. We know diabetics have a high risk of heart disease, so the answer is we want to get their LDLs down. So the rest of us with other risk factors, we can keep our LDLs around 100, but if you're a diabetic, if you have coronary artery disease, angina, peripheral vascular disease, you've already had a stroke, we want to keep yours down around 70, your LDL. Low, 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 low. If you're perfect, you can keep your LDL around 130, which means you have a waist size of 16 inches, you exercise 23 of 24 hours a day, you never eat any sodium, you don't have high blood pressure, your family history is beautiful. I mean, if you're perfect, then you can keep your LDLs around 130. Anybody? It's always one person that raises their hand. Okay, so here's the list of what your statins do, you all. Just amazing. Look at the list of what they do. They decrease your total cholesterol, they decrease your LDL cholesterol, they decrease the oxidation of LDL cholesterol. What does that mean? When you oxidize, you put it into arteries. So you reduce the risk of even putting it into arteries. Shrink plaques. The fat that's already there with the plaque formation. You can shrink the plaques, improving blood flow to your kidneys, improving blood flow to your other vital organs. Stabilize the plaques. The reason you have a heart attack and stroke is because the plaque has ruptured. These stabilize the plaques so they don't rupture and cause the heart attack and or stroke. What triggers the actual rupture is inflammation. These are potently anti-inflammatory drugs. They prevent the formation of new plaques. They decrease mesangial proliferation. What the heck's that? The only people that would know that would be dialysis nurses, because you know there's a group of cells in the kidney called mesangial cells, and those, when they proliferate, increase pressure in the kidney. And they boost neurogenesis. Oh, they decrease vascular inflammation, and they boost, actually, neurogenesis. They give you new neurons. Statin drugs actually help produce new neurons. Now, we're not sure if the neurons work or not, but we know if you have statins, you die with more neurons. I bet that's the best I can tell you on that one. Now, neurologists are very excited about this piece of information, if you think about it, because boosting neurogenesis, if they do work, then there may be a way to stave off some of the dementias that are out there today, besides working longer. I'd rather take a pill. All right, side effects, of course, we all know. Myalgias, muscle aches and pains. And here's the bad news. Everybody's read about this in Prevention Magazine and in Martha Stewart Living and in Oprah and all the magazines they read, that the statins cause your muscles to hurt. Well, they do in some patients, but not in everybody. So they did a study giving placebo and giving statins. There was just, and nobody knew what they were taking, but there were just as many people on the placebo who had muscle aches and pains as people on the statins. I'm not saying it's not real. Of course it's real. But we all have been programmed to think they cause muscle aches and pains. How many older people have muscle aches and pains? That's the other problem, you all. Oh, man, my muscles are killing me. It's got to be the statin. When did you start the statin? Last week. How long have your muscles been hurting? 17 years. So we get these answer questions. You need to ask how long it's been going on, where is it, all those questions. We also know that in many instances, vitamin D deficiency can cause muscle aches and pains. So a lot of people are vitamin D deficient. The #1 cause of muscle aches and pains in the elderly is thyroid disease. Check the thyroid. Do a simple test called TSH. And if you're hypothyroid, your muscle aches and pains will be worse on statins. And then we have the gentleman coming in. Barb, my muscles are killing me. They're just killing me. Are you on Viagra? Yes, I am. It's your Viagra that's causing the muscle aches and pain. Whoa, whoa. They don't hurt so bad. Not quite as bad as I thought it was. Anyway, so your ED drugs, your erectile dysfunction drugs, can cause muscle aches and pains. So there's lots of reasons for muscle aches and pains. It's not always a statin. All right, about 1 in 20 patients experiences muscle aches and pains. All right, so what can we do about it? First of all, we check to see all the different causes. We'll talk about all the way down at the bottom, switch statins. we actually see that some people have less muscle aches and pains on pravastatin. That's a good one to switch to, Pravachol. Lower the dose of statins. What dose did I tell you we start out with? A higher dose to begin with. So what can we do? Cut back the dose. Last but not least, a new study just came out a month ago, talked about giving the statins every other day. Every other day dosing reduces muscle aches and pains. And with just as effective as far as lowering the LDL. So that might become actually clinical practice to give a statin every other day. Fabulous, you all. You say, well, Barb, how do I know if it's a really bad muscle ache and pain? I mean, what should I do to monitor that? How do I know they don't go into rhabdomyolysis? If they have severe muscle aches and pains on statins, you will draw a blood test called CK, creatine kinase, that tells you if they have breakdown of skeletal muscle, CK. If it's slightly higher than normal, don't worry about it. If it's 20 times normal, worry about it. You'll stop the statin. Okay, I've told you about simvastatin being the highest doses, the riskiest statin for rhabdomyolysis. Never use the 80 milligram dose. Lots of drug interactions with simvastatin. And do not drink green tea or eat grapefruit or grapefruit juice with this statin, period. And then how about adding CoQ10? Are you familiar with this possibility? People talking about CoQ10, you all, is actually known as ubiquinone. It is a substance found in muscles, skeletal muscles, that helps you to have an energy for those muscles. Statin drugs tend to deplete muscles of CoQ10 or ubiquinone. Does that actually cause the muscle aches and pains? We're not sure. We're not sure, and neither are the cardiologists. But if I had 100 cardiologists in the room, 50 of them would say what to patients? Take CoQ10. The other 50 would say, it's BS. Here's my point. If you want to try it, it's another $60 to $100 a month for patients. It's not covered by any insurance or $4 copay. And they have to try it for how long? 3 months. So, this could be expensive for some of your patients for something that is certainly not proven to work for this particular indication. Okay, enough on that. Let's see what we got here. Let's talk about another drug that everyone in this room should be on. I am telling you, this drug is truly a miracle drug. Metformin. It is, not only does it have a favorable lipid profile, but we also know it as the #1 oral drug for type 2 diabetes. You know that. I know that. It's been out since about 1995 or so. It's been out about 20 years now. Also called glucophage, glucophage XR, extended release, Fortamet, Glumetza, Riomet, lots of brand names for this. Does absolutely have no effect on releasing insulin from the pancreas, which means it doesn't cause what? Hypoglycemia. That's why it's one of the best drugs out there. It doesn't cause your blood sugars to drop. Where it works is in the liver. It stops you or reduces the sugar production. The breakdown of stored glucose is called glycogen. It stops the production of glycogen turning into glucose, so you don't make extra sugar. Then it says, anything that's extra, we're going to put it into the GI tract. So you throw the glucose into the GI tract where you poop it out. Now, when you lose extra glucose through the GI tract, you're also losing calories. So what's one of the side effects of metformin? Weight loss. When you put extra glucose into the GI tract, the bacteria in your GI tract, of which there are 2 pounds of bacteria in your GI tract. You want to lose weight? Get rid of all the bacteria in your GI tract. 2 pounds, but those bacteria turn the glucose into methane. So what's another side effect of metformin? Gas. No friends. There are metformin support groups out there. It also can increase the sensitivity of receptors for insulins. So it boosts insulin sensitivity. It's a great drug, you all. It really is. Your biggest side effects are the GI blues. So think about giving it at night, and you'll just blow your husband out of bed. If you both take it, sleep back to back. Giving it with food helps to reduce the side effects. Giving the long-acting metformin reduces side effects significantly. So if they're on the shorter-acting one, switch them to long-acting, and you can get the gas reduced as well. And the diarrhea. Now think about it. You've got a lot of sugar in the GI tract. It pulls water in. It's a diarrhea-retic. So it can literally cause some diarrhea. And the bad news is you're having diarrhea, but you also are having gas. So you don't know if you're going to have gas plus diarrhea or just diarrhea. It's like, whoa, whoa. All right. But before you can even consider using this drug, you must check renal function. You don't just write a script for metformin and send them home without doing a serum creatinine. That's bad practice. Bad practice is called mal. So the reason is metformin's got to be excreted. You don't want it to build up. You don't want it to not be filtered and excreted because it can cause acidosis, lactic acidosis. It's a rare side effect, but it's rare enough that you don't ever want to see it. So, any questions about this terrific drug? Alrighty, so look at all the benefits. Cardiovascular benefits, lowers your blood pressure, increases your HDLs. I'm not quite sure we really care anymore about HDLs. This is annoying. How long have I been teaching? Too long. But I've been spouting out about the importance of HDLs all these years. It's an independent variable for heart disease, blah, 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 blah. Well, they then did a big study with a drug that boosted HDLs to see if that would protect the heart. Not a single person had any protection whatsoever with a direct boosting of HDLs. Well, that just knocked the socks off of all the cardiologists, thinking that if we had a great drug out there to boost HDLs, it would really help protect hearts. Hasn't done it. So I'm not telling you not to do it, but you might not want to be so focused on boosting HDLs. It's better to be focused on lowering the LDLs. The other big study that came out recently showed that fish oil does really nothing for the heart. Now, doesn't that knock you? How much salmon have you been shoving down your throat? Do I really have to eat salmon again tonight? Or the fish oil capsules have not been shown to be cardioprotective, primary or secondary. They do marvelous things for your brain and your eyes. So omega-3s protect your eyes from macular degeneration, protect your brain. They're great for the brain and the eyes, but right now, for cardioprotection, we are not recommending them anymore. So, you still want a brain and good eyes. It's just don't count on them for your heart. All right, anyway, so metformin and breast and prostate. Now, this is one that the oncologists are chomping at the bit. They're running around really excited about what metformin does for cancer. There's a pathway in the world of cancer, in other words, the loss of control of growth of cells. And there's enzymes in this pathway. And metformin actually inhibits an enzyme that stops the proliferation of cells. Why is this fabulous? Because in one longitudinal study, it was a 10-year study, breast cancer and prostate cancer were reduced by 54%. Wow, two of the biggest cancers, well, in industrialized nations. You don't see breast and prostate in Africa. You don't see cancers like that. But in the industrialized world, we absolutely. A reduction by over 50% is a huge wow. A few more studies, just a quick one. It also showed that metformin slows down lung cancer and pancreatic. Now with pancreatic, you usually die within 24 hours. It'll slow it down to 36. I'm not making light of that, y'all. I've had quite a few friends who've died of pancreatic cancer, and it's a fast disease. You get it one day, and it's like you are gone. Horrible, horrible disease. So is lung cancer. Not a lot going good news on lung cancer. Excuse me. I do have really good news about cancer, though, we're going to talk about later on. There's some drugs out there that are unbelievable drugs today for cancer. So, very excited. Anyway, so you may be seeing metformin prescribed for cancer therapies.
Are these breast and prostate cancers that have already been diagnosed?
No.
Like at stage 2? Or
Nope. Prevention. Totally.
Right.
Mm-hmm. Slows down the lung and the pancreatic cancers that have been diagnosed, but for this study was just prevention across the board. Okay then, so metformin slows the aging process. Wow, that's interesting. And so does omega-3 fatty acids. So another benefit of fish oil, forget the heart, but it slows down the aging process, helps protect your brain and your eyeballs. Metformin slows the aging process as well. You know, diabetes, you all, is an accelerated aging. When you have diabetes, your tissues age faster. So by using metformin, we can slow that process down. Metformin boosts neurogenesis, along with your statins. So we'll see what happens with that. Neurologists are very excited. Now here's another interesting one. You psych nurses in here. Those new drugs called atypical antipsychotic drugs, compared to the old antipsychotic drugs, Haldol, Mellaril, Navane, Thorazine, remember those horrifying things? Well, you know, those old drugs had the extrapyramidal side effects. Everybody hated those. You know, you became Parkinson-like, and then if you didn't do that, you were having all that tardive dyskinesia. Horrible side effects. Taking a psych drug? So it was awful, awful, awful. So then they decided to make new drugs that were going to not give you the EPS effects because of their effects on what are called dopamine 2 receptors versus the dopamine 1 and dopamine 2. Okay, so they moved them into what were called atypical antipsychotics, which we all know as clozapine and olanzapine, which are Clozaril and Zyprexa, Geodin, all those drugs. Do you know why they call them atypical? I laughed out loud when I read this on the plane. This is hysterical. It has nothing to do with different side effects. It has everything to do with how rats climbed a pole when they were researching them on these drugs. So all I could think about was a pole dancing rat and how they dance differently on a pole compared to Haldol. That's why they call them atypical. And now the guy next to me said, "What's so funny?" I had to explain it, but he didn't seem to get the humor. So anyway, so our atypical antipsychotics. We have traded one set of side effects with the tardive dyskinesias and the Parkinsonism features with another set of side effects called hyperlipidemia, hypertension, and obesity. Two different sets of side effects. So now we have fat cardiac schizophrenics. And please trust me, I'm not making light of this. It's just so crazy. So we now have a whole group of schizophrenics who are obese, diabetic, with hyperlipidemia. Here's the good news. If you start them on metformin the exact same day you start them on Zyprexa, you prevent the obesity, the diabetes, hypertension, and hyperlipidemia. 1,000 milligrams of metformin started immediately will prevent all those side effects. Wow. Now the study's only been done in women right now. That's fine, because I always do everything in men. This is phenomenal, you all. This is a very phenomenal study. A psychiatrist should absolutely be aware of this. I mean, because once we switched them all these diabetes, then we had to give them insulin. I mean, it's like, oh my God, now we got a schizophrenic trying to take insulin. So, that being said, the second thing we're showing is if you've got to start somebody on high-dose prednisone, I mean high dose, not therapeutic dose, not physiologic dose, which is 5 to 7.5 a day. I'm talking about 40, 50, 60 of prednisone. Start them on metformin the same day. You stop the secondary diabetes and the weight gain. It's a great drug, you all. Metformin is a fabulous drug. A little trade-off with a little diarrhea, a little gas. But I think I'd rather that than a 150-pound weight gain and a few other things that we can horrifyingly see. And last but not least, metformin is now the drug of choice for young girls with PCOS, polycystic ovary syndrome. It will make you start to ovulate very quickly. So if you are not in the mood for children, you'd better start also on what? Birth control. Now, a lot of these young girls are actually in fertility clinics. They're there because they want to get pregnant. So that's great. When we put them on metformin, bingo, within 3 months they're all pregnant. But if you're not in the mood to get pregnant, then I would suggest an IUD, something. So look at all the uses of this amazing drug. Pretty phenomenal drug. Another complimentary handful on your way out today. All right, downside, B12 deficiency. This is important. So we have to think about your diabetics and a B12 deficiency with metformin. And why I say this is because generally when B12, one of the results of B12 deficiency is neuropathy. Now you've got a diabetic with neuropathy. What do you immediately attribute it to? Diabetes. But it could be their B12 deficiency. Hence, I recommend every single diabetic that is on metformin should also be on B12, as do most diabetologists today. Go ahead and start them on B12. It won't hurt, and if anything, it will help. So the side effects of gas and diarrhea, we can kind of work around those. You can also use Imodium for the diarrhea, you all. If you know that a drug is causing diarrhea, Imodium is a perfectly safe and effective treatment. And generally the diarrhea will go away in the first month, especially if you switch them to a long-acting. But if you don't know what's causing someone's diarrhea, you never give them Imodium, ever. It could be a foodborne illness that you do not want to stop. You want to get whatever bug is out of there. So if you have no clue what's causing the diarrhea, then just don't stop them up. Okay, another big group of drugs out there today for diabetics are called the incretin mimetics. Yes, ma'am?
I have a question. If you have a patient on high-dose prednisone and you're giving them metformin, does it also help with the out-of-control blood glucose level?
Sure, absolutely. It'll help to stabilize them.
Type 1 and 2, or just type 2?
I've never seen it used for type 1, although there's some studies showing that metformin, since it boosts insulin sensitivity, in kids or young adults that require really high doses of insulin, it can actually help reduce their dose of insulin. So I think you're going to be seeing, there's no FDA approval for type 1 diabetes and metformin, you all. But we are looking at investigational studies for kids who are on 100 units of insulin a day, way off of the charts. Metformin helps to reduce the dose. Okay, whole new group of drugs called the incretin mimetics. Who in the world has ever heard of incretins? I heard of a cretin when I was in school, but that was a kid that had congenital hypothyroidism. They were called cretins. It wasn't a very nice name, but that's what they called them. Actually, the word cretin means Christian. You can call your head nurse a cretin. If you quickly tell her that it means Christian. But anyway, incretins are substances that are produced by the small intestine after a meal. We never knew these existed until they started doing research, interestingly, on the saliva of a Gila monster. What the? Who would be doing research on the saliva of a Gila monster? What wackadoodle would be thinking about that in the middle of the night? Well, believe it or not, there's wackadoodles out there that think of those things. And the reason they think of those things is because Gila monsters, which live in the desert in southwest United States, only eat 2 meals a year. They eat a meal and they are absolutely satiated for 6 months. So they were looking at what could cause you to feel full, which would do wonders for weight loss. Correct? Correct. So they had these Gila monsters. They were milking for their saliva. And they found this substance that actually boosted something called incretins in the GI tract. This is a whole new finding, whole brand new finding in the 1990s and 1980s. So anyway, let's fast forward. The incretins are impaired in diabetes, type 2 diabetes. You don't release them as well. So they said, well, let's go ahead and pump them up and see what happens. So you pump up the release of the incretins post-meal, and that lowers your sugar and makes you feel full. So the first one came out was called exenatide Byetta. Byetta from the bite of a Gila monster. That's where the name comes from. Literally, y'all, Gila monster. If you ever see one, if you're out there walking in the desert of Santa Fe and you see a Gila monster coming at you, it's what they look like. Nasty looking. If they're waddling over toward you, what should you do? Run! But they run at 9 miles an hour. You'll never outrun them. If they're hungry, they're latching onto your leg, and what won't they do? They won't let go until they've taken your leg off. You can drag them with you to the emergency room. Yeah, they're really mean when they're hungry. So when you go back in a few more years, the other leg, they'll see that you need one more leg. Anyway, so fast forward. We've got now Byetta 2005. It's a shot. You gave yourself twice a day, before breakfast, before dinner. Blood sugars would lower, and you'd feel full. You'd also feel nauseated. This kind of makes you nauseated, which makes you not want to eat either. But weight loss was a side effect. Then they have one that's once a week now, tolerated much better. It's called Bidurion. Okay. Nausea in 14% of the Bidurions versus Byetta, which is 35%. So obviously giving it once a week is much better than giving it twice a day. But I'm not done yet. Indications: type 2 diabetics who are already receiving metformin, sulfonylurea, or both, and do not have optimal control. We don't start with this drug. It's more of an add-on. Okay, side effect: weight loss and slowing of gastric emptying, feeling full. But we have a better drug out, and that one is called the second generation liraglutide, Victoza. This one is once a day with less nausea. Now, the new face of Victoza was the Butter Queen. But she was an idiot. Anyway, so we now realize the drug company dropped her because of this whole big brouhaha. So she is no longer the face of Victoza, but I will tell you this, and this is very important about these drugs that boost incretins, no matter who it is that boosts incretins in a roundabout way or a direct way. You've got to be very careful because they can trigger pancreatitis. And a diabetic who comes in with severe abdominal pain that is on Byetta, Bidurion, Victoza, or any drug with the last name gliptin, which we're going to get to in 1 second, you've got to test them for pancreatitis. What are your tests for pancreatitis? Blood test. Amylase and lipase. Absolutely. Pancreatitis, y'all, is not just a little inflammation here. It's a significant finding. Now, I'm going to bring up this piece of information, but I don't want you to run out of here screaming. There may be a slightly higher risk of pancreatic cancer on these drugs. It is absolutely not definitive, but when they have taken the pancreas, they looked at pancreases of people who have died, and they look at them that have been on the incretin drugs, they see hyperplasia, meaning the pancreas has more cells than they should have. The growth of the pancreas is occurring. So they're a little concerned. There's no big black box warning right now. There's not taken off the market. They still can't prove anything. But do we all know that inflammation contributes to cancer? You bet. Inflammatory response. So we'll see. I have friends on this drug for weight loss. It's not approved, but her endocrinologist has given her a weight loss, Victoza daily. She lost a pound a day for about the first 3 weeks. Literally lost 15, 20 pounds in the first 3 weeks. Okay, she's now in intensive care unit with pancreatitis, but she's looking pretty good. Just kidding. She's lost a lot of weight now that she's on enteral feedings. Just kidding. All right, so. Okie dokie, now our gliptins, another new group of drugs. You know, there's like 11 classes of drugs now for diabetes, you all. Lots to choose from. Back when I was first in nursing school, there was Tolinase, Diabinase, Ornase, and every insulin came from an animal on the farm, right? bovine insulin, porcine insulin, asinine insulin. Pick an animal. We grabbed its pancreas and sent it down to Indianapolis. Great story. Great story. The stockyards of Chicago supplied all of the pancreases for the insulins starting in the 1920s up until we started getting recombinant insulin. Literally a train full of pancreases would leave Chicago every day, and the train went right into the building, Eli Lilly's building, in downtown Indianapolis, and they dumped the frozen pancreases right on the floor, and they started extracting the insulins. That's an amazing story. Fascinating, an amazing story. We don't do that anymore. We don't have to go to a farm and grab a pig and get its pancreas like we used to, but it was just a really fascinating story. Okay, so these drugs are called the gliptins. They are weight neutral. They don't make you lose weight, but they don't make you gain weight. All right, so they inhibit the enzymes in the intestine responsible for breaking down incretins, and incretins potentiate insulin release. So we've got sitagliptin, saxagliptin, linagliptin. We have, well, there's the three of them now, Januvia, Onglyza, Tradjenta. Then we also combine them with metformin. Why not? Metformin is a great drug to combine everything with. So we have Genumet, Combiglize. We have Genta Duetto. You're taking a Genta Duetto for your... So, and of course, these also cause pancreatitis. So, don't ignore acute abdominal pain in a diabetic on any gliptin or any incretin mimetic. Okay, then. What would you think about if you had a 62-year-old patient that presents with weight loss and type 1 diabetes? Well, high blood sugar, weight loss, and they are diagnosed with type 1 diabetes, meaning they're not making any insulin whatsoever. But they're 62. That is the red herring here. Pancreatic cancer is usually the cause. Significant weight loss, type 1. Now, type 1 diabetics, when they're 12, lose weight, right, because of the disease. But when you're 62, it's rare to see a new onset of type 1 diabetes. Extremely rare. So if you see it, they have weight loss, you've got to check the possibility of pancreatic cancer. All right, how about old drugs for type 2 diabetes? Why do we even bother with these drugs, you all? You know why? Because they're cheap, and that's just no reason to use them. But they are cheap, and of course we are, bottom line here, we'll spend $92,000 for a vaccine for prostate cancer that keeps you alive another 3 months. That just drives me crazy. And we have to skimp on diabetes drugs. That new Provenge, I think it's called Provenge. You know the name of the drug? It's an injection, a vaccine for prostate cancer that gives you another 4 months. No offense, Mike, the only prostate in the room. We love you. But, come on, for $92,000? You know who approved it? Congress. They're all a bunch of old prostates up there. God. Anyway, so the sulfonylureas, you all, they've seen their day. They're old. They're tired. They also make you gain weight. They give you hypoglycemia. They increase your cardiovascular risks. And we're still using them. The only one that is in any way safe in the elderly is glimepiride, which is Amaryl. It causes less hypoglycemia. But you still see the glipizide and gliburides. It's crazy. And who has the biggest effects from hypoglycemia? It's not a 22-year-old. It is a 80-year-old. Fall down, break a hip. Oh, well, we shouldn't have been using that drug. Sorry. Arrgh.